The Galen Centre for Health and Social Policy, in collaboration with the Cancer Care Working Group and with the support of the Pharmaceutical Association of Malaysia, PhAMA, organised a webinar on managing pain and palliative care in cancer during the MCO on 7 May 2020. The webinar discussed the experiences of cancer patients who needed pain management and palliative care, as well as the experiences of healthcare providers who strive to meet the needs in community and hospital settings. At this point of time, a nationwide Conditional Movement Control Order, or CMCO, is in place until 12th of May 2020, which is gradually easing the weeks of restricted movement imposed in an effort by the government to combat the spread of COVID-19. The webinar is the third in a series on cancer care and COVID-19. The amount of data we've received in daily updates on COVID-19 patients far outweighs the current information we have on the degree of inconvenience and suffering experienced by patients living with chronic diseases such as cancer during this period. While death and dying from COVID-19 is very much on the forefront of everyone's minds, the experiences of people living with cancer who are being treated with palliative intent are suffering from pain or have even passed away during the MCO period. The difficulties faced by their families and caregivers have garnered much less attention compared to those suffering from COVID-19. What is the impact of this challenging period on pain management for cancer patients? What are the gaps faced by providers of palliative care? What are the actions needed to improve the quality of care and the coverage and depth of palliative care services? What are the challenges faced by those providing cancer care in both community and hospital settings? To help address some of these problems and some of these questions that have been raised with regards to managing pain and palliative care, we have two speakers that will be talking in today's webinar who are very much experienced in these two areas, especially in the provision of quality care for people living with cancer. The first we have is Dr. Ednin Hamzah, who is Chief Executive Officer for Hospice Malaysia. And our second speaker for today is Dr. Martin Malor Abdullah, who is the Consultant Clinical Oncologist at the Subang Jaya Medical Centre. Gentlemen, welcome to today's webinar.
Thanks, Azrul.
So it is something of a challenge for many of us today, especially dealing with the COVID crisis, that we are having to deal with a new way of work where we're doing a lot of these webinars, consultations through online services, etc. And it's a new way of us interacting with patients, with clients, with people who are looking towards a new way of addressing concerns and needs, particularly from a medical setting. So I would like to ask both of you, where are you speaking from? Where are you talking from right now? From Dr. Ednin's side, I see it's actually out of this world.
Absolutely. Keeping well away where the virus is not around.
Well, you're not saying where, huh, Ednin? Yeah, I'm doing it from home because today is Wesak Day. You know, as with all Malaysians, we share in the celebration, and because it's a public holiday, I'm at home observing the MCO.
So it's definitely something of an experience, but both of you being doctors, I can imagine you have been very much out there working despite the MCO and the CMCO being put into place. Are you seeing a lot of patients?
For me personally, absolutely. the MCO really hasn't affected me very much as far as restrictions of movements is concerned. Because I work in a hospital, so I do my fair share of work. And of course, after work is straight home, no more socializing. That's the difference between then and now.
How about you, Dr. Edmund?
I found it interesting navigating around the Klang Valley with MCO because I do community work. And it was interesting because although there were very limited traffic around in the first few weeks, getting past the roadblocks was quite interesting because the police officers understand there is such things as community care, and that it sometimes hinders the ability to get to patients' homes, because even though you may get past the checkpoint, it might take you an hour or 2 hours just to get to the checkpoint to be let through. So quite a bit of time sometimes spent negotiating past roadblocks. And then you have got all the other issues about seeing patients in the community in terms of fears and anxieties.
And I presume that both of you have superior negotiation skills now because you're able to negotiate through roadblocks?
Well, for me, Azru, I didn't have to negotiate because I've got a piece of paper from the management that says I'm required essential service, and I've got this big notice I put on the front of my windscreen. But as Edwin said, I think when you're faced with a roadblock, you're right at the back of the roadblock. Although you are given preferences to pass through, but to get to the policeman to then give you that led you to the path that led you past the roadblock, that takes a bit of time sometimes. But for me personally, because I stay in Damansara and I go to work on the Federal Highway and the NKVE, I'm not faced with any traffic jams at all. I'm not faced with any roadblocks. So for me personally, I'm fine. But I know that some other physicians and surgical colleagues who stay in, say, Kajang, for example, coming to work on the Seremban Highway, coming into that was a challenge. But having that notice to say that you work in a hospital, essential service, that helps very much in expediting the negotiating the traffic jams.
So essentially, we're looking at a different way of doing work, at least during the MCO period. So I don't know how the CMCO is going to be affecting many of the services that you are providing. I presume, Dr. Martin, you're hospital-based, right? And Dr. Enin, you
Yes.
are operating from Hospice Malaysia. So you're in the community itself. So two different individuals looking at working in a different way. And many of the people that you're working with are cancer patients, which is the topic of the discussion today, right? So let me just start off with addressing the issue that we have with us on the table today, which is managing pain and palliative care in cancer during the MCO. So let's start off with a basic question first to Dr. Ednin. Can you tell us, and I'm not wanting to assume, what is pain and what is palliative care?
Okay. Pain is essentially it is something which causes intense suffering to a great deal of cancer patients. And it essentially has two components. Most people look at the physical component, but the other component of pain is usually psychological existential component. And so it is whatever the patient says causes him pain. So that's the simple answer to it. So you just ask the patient, have you got pain? And he says he has. You just then have to find out how much of it is physical pain and how much of it will be non-physical pain. Palliative care is essentially something that can work very well with oncology care. It is dealing with the effects of an illness in terms of how it affects quality of life. And what we try and do in palliative care is work with disease-modifying treatments to alleviate pain and suffering.
And how much of that within the context of what you just described, Dr. Martin Mello,
Yep.
Can people living with cancer are able to, how much of pain and palliative care comes into the life of a person living with cancer?
I think pain is a major component of the care of patients with cancer. I think probably as much as 80 to 90% of patients, we're talking about patients who have got life-limiting disease. We're not talking about patients in whom cure is the eventual goal of treatment. So we're talking about patients with stage 3, stage 4 disease. And at some point during the journey, the cancer journey towards, unfortunately, with advanced stage 3, stage 4 disease, eventually patients who do succumb to the disease. And during that journey of eventually succumbing to the disease, pain is a major component. And a lot of patients do have pain of varying degree. And a lot of our work as oncologists also involves managing pain, physical pain, as well as spiritual and mental pain that patient undergoes. So what Edin is doing is very, very commendable, trying to manage that. But there are components of pain management that Edin can't do. For example, if patient requires radiation therapy for a physical pain due to a fracture, due to a bone metastasis, that medicine can only help so much, but for the forms of intervention like radiation could help that. And obviously that is something that has to be done in a hospital setting and can't be done in a community setting. No voice.
Okay. So
Yeah,
we want to be able to understand what pain is within the context of cancer. But I don't think, unless we are living with cancer, are we able to really appreciate the thresholds of pain. And this is where perhaps Dr. Edin, Hospice Malaysia has been working to help patients, not just those living with cancer, but also those with other diseases as well, and those who are coming towards end of life. How do is there a measurement of pain?
The simple thing is that the most common way is using pain scores. Is asking a patient how bad is your pain, and the basic pain score would be that 0 is no pain and 10 is the most maximum pain that you can imagine. And you basically will ask the patient, how bad is your pain now? And the patient normally will give a rating, say 5 out of 10 or 7 out of 10 or 2 out of 10. That's a very simple way of trying to assess how much a patient may impact, how much a pain may impact a patient. That would be the simple aspects of how the patient appreciates it. You then have to ask more questions to identify where the pain is, the location, and what is the cause of the pain. And for cancer patients, typically they may have more than one source of pain. They may have bone pain, they may have pain from the organ that has the cancer, they may have other sources of pain. So that the assessment of pain in a cancer patient does require some careful consideration, and then the management may be multimodal, as Dr. Mello says, that some patients, say with bone metastases, they would certainly benefit a great deal from radiotherapy. Some patient with psychological pain would benefit from some counseling intervention. So you do look at how pain impacts on a cancer patient and then assess the cause and plan a management for the appropriate cause.
So when we're talking about what happened during the MCO, where there was a restriction of services, people were not able to move or see, the carers were not able to go towards looking at patients who they were responsible for. There was a limitation of movement. How did all of that affect the experience of pain management and the services relating to palliative care, both from the patient and carer's perspective?
I think from my side was that in the hospital-based palliative care services, some of them were redeployed. Some hospitals were redesignated into COVID hospitals. So the normal care of some cancer patients in hospital was interrupted. So clinics were canceled, certain treatments were not able to be carried forward. coupled with an inherent fear of many patients in the community not to want to go to hospital. So they were quite fearful of going to hospital. Many cancer patients, for example, are on drugs such as morphine, for which supply was interrupted during this period. So then they tried to ration some of their medicine that they have at home, and thereby increasing the sources of pain. So I guess that's one of the difficult issues that we were having from many of our patients in not being able to access the normal medical care that they would normally have in hospital.
And Dr. Martin, you're at the hospital and you're seeing these patients come in. Did your patients experience any kind of difficulty or complication that was as a result of what they were experiencing during the MCO? Was there any interruption in the quality of treatment that was being provided?
Really, it really depends on which setting we are talking about. As Edin pointed out, in the public hospital with cancer facilities are then put on the back burner because of the designation as COVID hospital. You know, our 4 big public hospitals like UMMC, HUKM, IKN, and even HKL, the oncology services had to be curtailed to redeploy staff towards the COVID-19 situation. From the private hospital perspective, it's not really an issue. Access to the hospital is unimpeded apart from the restriction order. So the patients who do present themselves to the hospital are managed very much based on guidelines. But also want to also stress, as Edin would say, patients do have this fear, this morbid fear of coming to the hospital for fear of contracting COVID-19. But for those who does present themselves with a complaint that we can manage within the hospital, it's really not an issue. We're able to give the treatment as they require them. Just to add on, regards to the fear of coming to the hospital, a bit off tangent in terms of the cancer care, some patients actually did postpone their treatment, again on fear of coming to the hospital for fear of contracting COVID-19. So I don't know whether those fears are unfounded or not. Certainly, COVID-19 had been identified in certain hospitals, and SGMC there had been 1 or 2 cases of COVID-19 being identified in the hospital and then transferred on to Sungai Buloh. But for most instances, those who actually present to the hospital for palliative care and pain management, that very much went according to plan. So, like I said, it really depends on the point of entry. If it's in the public hospital, there's a bit of an issue. In a private hospital, not so much.
Azrul, one of the challenges that we were having was that we were given, we were certainly given advice from the Ministry of Health that any patient with respiratory symptoms going into a public hospital would be treated as a COVID patient until they are cleared. So therefore, some of the patients, for example, with lung cancer that may have pain and respiratory symptoms were very, very fearful of going to hospital and having to be put in isolation until they are cleared of COVID. So that has really interrupted some of their potential ability to manage the symptoms. And that travels quite a bit between patients.
That also happens in the private hospital now, Ednin, because those who come in with respiratory symptoms, again, on the basis of fear of COVID-19, the management actually mandate that they have a COVID-19 test, to do the test prior to doing any form of intervention. So I know a number of private hospitals are doing the same thing. They're maybe even implementing all patients that come to the hospital for admissions for any reasons would have a COVID test done before being admitted to the hospital for normal care.
So the Ministry of Health has already put out a standard operating procedures for even going for elective procedures or even general admission. There's really something that has really changed in the way that we're looking at taking in patients regardless whether or not they're being suspected for COVID-19. So
Yeah.
things have changed. But again, when we look back at going to the management of pain and palliative care, Dr. Edin, I have to say, until recently, when the ministry has started to talk about the vulnerability of aged individuals, people in old folks' homes, in those in assisted living, or people needing special treatment, there was not much that we heard of what was happening in the community with regards to these groups of patients. And certainly when it came to palliative care patients, I don't think we heard much of anything, but also we were not really aware as to what kind of challenges or issues were being faced by patients in this category of services. So you were in the community and you have been with many of these patients. Can you tell us a little bit what some of those challenges were and how we can address some of those concerns that are raised by these people?
I think it's quite sad that there really hasn't been very much interface with palliative care within our COVID response in this country as opposed to some of the other countries. We are now hearing certainly a great deal around the world about the death rates in the community, especially in care homes, and that these are particularly vulnerable patients. I would say that certainly many of the cancer patients that we have both fall in the more elderly age group, as well as you have more of them in care homes and other such facilities. There are several things that has affected the care and pain management. One is the ability to access assistance. Many of these patients do depend on family members to come and care for them. And the MCO has affected the ability of siblings, children to come and help their parents with cancer and others. And this has impacted on some of the caregiving ability and to some extent pain and symptom management. For patients that have difficulty coping, if they want to access things like private nurses, private care, being put into nursing homes generally has stopped accepting outside new patients, so that they just have to manage essentially by themselves with whatever resources that they have. And this has really made life much more difficult in the community. As I said, sometimes there are medication issues. So if, for example, even if you do have the right medication and you prescribe certain medication to be given at particular times, if there isn't a caregiver there that can provide the medication in a timely manner, that certainly will affect the experience of pain. So that I guess that's one of the things that we are seeing.
But there is still a question of what are those services? Because we don't get enough exposure to this issue of palliative care, what are we talking about? Are we talking about specialized nurses? Are we talking about equipment that's needed? A facility? If we're talking about care in the community, what are they not having? What are they not getting?
I think the main thing that we are getting from our patients is the isolation. And I find that the way that we're handling is in talking about, say, social distancing. I disagree with the messaging, because I think that what we really mean is we're talking about being physically distant, but we are human beings, and human beings are socially connected. So by saying social distancing and not providing ways of how people should still keep connected and how we could offer support, that creates this sense of fear, anxiety, and social deprivation. So from my part is that we are continuing to maintain telephone contact with our patients as often as possible, and sometimes to visit them, even when they say things doesn't seem too bad, because sometimes even when they say, I'm okay, when you go to the house, they're not okay. So I think that there's one is that connectivity. The other thing is that there are specific aspects of care that cannot be done through telemedicine. So things like wound management, things like physiotherapy, you need somebody there to handle it. if you say that somebody needs a medication, there's no point if you think, I think that you have a pleural effusion or chest infection because you need that treatment to deliver to that patient. They need to get an antibiotic. They need to get that pleural effusion drained. If they need a blood transfusion, they need to go to a hospital facility. So they need that point of care to be delivered at that bedside for some patients.
Dr. Martin, we talk within the context of cancer patients, and we talk about palliative and pain management in a broader sense. When you talk about the experience of cancer patients during this period of the MCO, how have they been talking to you about these issues that Dr. Ednin just raised? Are they actually facing some of these concerns?
Yes, they are. Yes, they are. The patients that I deal with are mainly within the hospital. But obviously, the patients don't stay in the hospital for very long. They get their issues sorted out and they go home. And at home is when the care can be compromised on accounts of medications. You see, when patients have got pain at home and they are on a certain types of medication at some point, things change. So they may be on, whilst they're in the hospital, they had pain drugs that controls their pain, but when they go home over a period of time, things change, and the pain management might need to change, and then access coming back to the hospital becomes an issue. And if the patients with the MCO, they're only allowed early on, they were not allowed to have anybody with them, and only later they were allowed to have one carer per patient. I suppose one of the things that facilitated that from the hospital point of view is to giving every patient a letter to say that they are patient with cancer and they're coming to the hospital for any particular procedures that needs to be seen. And I must say that as far as the police is concerned, they do recognize those letters and allow those patients through the roadblock, albeit with a bit of delay in terms of time. Yeah, so those are the main issues. But as far as pain in the hospital is concerned, it's really not an issue.
So it's a fortunate situation that if you happen to be in the hospital setting, then you have treatment that's able to be delivered, that's able to manage opioids that are accessible. But in the context of managing pain and palliative care within the community setting itself, it is a huge challenge. So doctors, we have a number of questions that are coming in through the group chat right now. So I just wanted to remind everybody attending, we have around 75 participants that if you want to have your questions answered, just please send them on the group chat and I will put forward these questions to our two speakers. So one of the questions that we have here, as a cancer survivor and a senior citizen, pain is something I live with every day. What nature or level of pain will require further investigation? Dr. Martin?
So I think, as Edin said, I think it's important for that individual to then have a conversation with the doctor, because we need to know what kind of pain it is. Is it a physical pain? If it's indeed a physical pain, we need to investigate and find out what is the root cause. As with everything in life, we need to find the root cause and manage that accordingly. If it's a psychological pain, that has to be managed in a different way, not so much in the pharmacological way. So senior citizen living with certain level of pain, one needs to know what that is. It could be age-related osteoarthritis, and that needs to be managed as well. Not like a cancer pain, but referring accordingly to the orthopedic surgeons who would manage the pain with physiotherapies and such like. Yeah. So root cause needs to be investigated first. So I think the first port of call would be to see somebody, have a discussion, discussion about the pain, and trying to find the root cause, then manage it from there.
Thank you, Dr. Martin. There's another question here, which I'll ask Dr. Ednin. We have patients and carers who are often their family members, close relatives who are living in the same home, same apartment, same condo, same house, and they're taking care of someone. sometimes people outsource, the work of caring for the individual to a nurse who comes regularly to the house and is able to do what's necessary. And suddenly, because of the MCO period, because of the CMCO, suddenly you are put into this position where you are not familiar with you. I mean, you see the person every day, but suddenly you're also having to act as a nurse. So a basic question really is, what are the appropriate and comforting words we can say to patients in pain?
Okay, two parts there. One is that what we are doing sometimes is that family members suddenly now have to be caregivers in their own right. Yeah. And they need specific skills for which they are completely unprepared to do. You can try and run through certain things they can do on telephone, but sometimes it is very, very difficult to do physical care, sort of talk them through doing physical care just on the phone. And that's where we send nurses and physiotherapists to the homes to teach them how do you do the nursing care transfer, how do you feed, how do you manage physical aspects of care. In terms of dealing with words of comfort to patients with pain, one of the things we get a great deal from patients is that the families do not believe them.
Really?
Yes. And typically that many cancer patients have got pain that need regular medication. And many family members actually withhold medication from patients because they don't think this pain can be there all the time. And sometimes the nature of pain changes because of the situation. The cancer may be progressing, the environment, the psychological aspects may make the pain seem worse, and many other reasons. So one of the main things that many cancer patients feel is that they're not being believed, that their pain is not being believed by their caregivers and family members. So one is that believe the patient. If the patient says, I have pain, believe him or her. And then try and think about, do we need to get in touch with healthcare professionals to adjust the level of pain medication? The other part would then be to empathize with the patient. Don't negate what they are saying. Sometimes, the public and others keep going into things like what they feel might be reassuring as be positive, be brave, these sort of war analogies that are often used in cancer. It's not always useful because the patients may feel that they're not brave enough, that they are failing. So it is important to say, it must be hard for you to have this pain. Can you tell me more about it? And let them talk through it. You might not be able to directly relieve it, but try and empathize and understand the nature of pain. And sometimes just being able to ventilate how bad they're feeling makes them feel better. But if you give them a task to do that they can't do, put it out of your mind, just take it away, it doesn't really work. But you can use guided imagery or something like that to use reminiscence, to talk about something wonderful in the past that might bring a good memory to the patient. And that may allow the patient to be in a mentally better place where the pain becomes of a lesser concern. So there are some words that you can use in terms of psychological intervention that can minimize the impact of that pain at that moment. It may not last very long, but it can be very comforting. But to tell the patient, forget about the pain, it doesn't really work.
Dr. If I may add, Azrul,
yes, please go ahead, Dr.
If I may add, because again, from experience and this myth about not having chemicals in the body. So a lot of people, a lot of individuals have this perception that putting medicines into your body to try to manage your pain is like putting in chemicals to your body, and it's actually bad for you in general. In general, that's true, but here we're talking about patients who've got a physical pain or something which is physically wrong with them, that they do need these medicines. And it's very, very important to stress to them that the pain medicine needs to be taken by the clock, on time and by the clock. And that sometimes can be quite difficult, even for patients themselves, because some of them, if they do continue to take medicine, are perceived to be weak in some ways.
I mean, that's quite a a distressing situation for
It is.
For the caregiver to see. But imagine if you're the patient themselves and you're being treated this way, and you're describing it from a hospital setting, I presume, because we're presuming a lot that in the community setting we have these challenges where a caregiver who is also a loved one is expected to function as a nurse or a caregiver who is trained. But we are assuming that within the hospital setting, that these are much more less of an issue because you have trained individuals there. You have people who are able to listen, who are able to give the right words. Is that true, or is that just an assumption?
Oh, that's true. That's true.
Because that's quite that is quite refreshing to hear. Because we have one of the questions here from a staff nurse who is working for an NGO which is stationed in a government hospital, and she said that I had a patient calling in pain with a huge fumigating wound. She was on morphine. Her pain obviously was not well controlled. She was referred, and the doctor in the SOPD refused to refer her to palliative care or hospice. A week after, she was admitted for pleural infusion. Due to COVID-19, no family was allowed to visit. Unfortunately, the patient died a week after with no family around. Her question is, where are we exactly in educating healthcare providers on the importance of palliative care and hospice? Dr. Martin.
I think that's something that Eddie should answer, probably.
I want you to answer first, then Dr.
Yes, I know. But I think palliative care is, what people really need to understand is that a lot of care that we do in oncology is palliative care. And recognizing the lack of knowledge, I suppose, from non-cancer, non-palliative care individuals is important. To deny somebody a referral to a palliative care facility is actually criminal, really, because there are a lot of things that can be done to alleviate pain. So in oncology, and oncologists in general, we are very tuned to doing palliative care. And in fact, a lot of work that we do, in fact, is a form of palliation. For example, giving radiotherapy, chemotherapy for patients with stage 4 cancers. We shouldn't pretend that we are actually treating and curing those patients. Those patients are only, to some extent, buying time with the treatment that we're giving. And therefore, the treatment is, for all intents and purposes, is palliative.
Dr. Eddie, comment?
Oh dear, such a depressing question. It is. I think that certainly we are nowhere near adequate in the understanding and how palliative care integrates with our healthcare system at the moment. That is really a depressing story, which is repeated in many other settings. Patients with significant pain and then not being attended to and subsequently dies in isolation. It's horrible. The Ministry of Health actually has put together a national strategy for palliative care last year. So that paper has been adopted. The question is that, will it be implemented? So that's something to watch out for. So I think that the ministry has certainly put forward a plan to integrate palliative care, but we need to see the space as to whether there'll be any investment into this process.
Perhaps you could...
Azrul, I have a question.
Sorry, please go ahead, Dr. Martin.
Azrul, I have a question to Ednin. I mean, is the length and breadth of palliative care availability in the whole of Malaysia adequate? I think we could have a plan, but it requires implementation, requires personnel, and so on. With the current number of personnel that we have got, I personally feel that it's really not much, not enough.
Absolutely.
And to be fair with you, I think from the oncologist perspective, palliative care at this point in time is really a bit difficult to access. For example, if I've got individuals who wants to get admission and not admitting to a private hospital, going to a public hospital, for example. I know University Hospital has got palliative care unit, and the public hospital has got palliative care unit, but access to those are not easy. referral to the individuals with difficult, sometimes they access those palliative care through the emergency, and going to emergency in a public hospital is another experience altogether, So I think it's good to have it on paper, but I think we should have a target. Just like with oncology, we should have a target as the number we want to achieve for population size and so on.
I agree with you completely agree. I do not think there's enough investment put into it. There is not enough political impetus into it. It will take a good many years before we will get a reasonable coverage at the moment. I certainly don't think, based on the current numbers that we have, we would be even close to meeting the number of cases that we can help. What I would be wanting to suggest is that there are particular skill sets that particular palliative care can help with other specialties. And we've seen it in different countries, in Australia, in other places, where upskilling some of the oncologists, surgeons, and internal medicine in a few aspects of say, pain and symptom management, communication aspects can help these other specialties deal with that patients with palliative care needs, because of the lack of capacity in terms of the palliative care services that we have in the country.
So are we really talking about the number of people here? I mean, what are we talking about? Is it the physical aspects, or is it the specialists? I mean, how many are there in the private and public settings? Where is it concentrated? Is it mostly in the private sector, or is it mostly in the public?
Well, for palliative care, it's mainly in the public sector, and mainly in the Klang Valley. There's probably about 14 palliative care specialists in the country at the moment. I'm not so sure, maybe about 6 or 7 Ministry of Health hospitals have got specialist palliative care. A few other hospitals have got visiting services. In the NGO side, there's probably about 20-something services in the community aspect. Some of the private hospitals and teaching hospitals now have palliative care services. So certainly things have improved over the last 5 or 10 years, but we do need a huge amount of investment in this area. So nowhere
having palliative care services on paper is good, but whether it's actually being rolled out the way it should be rolled out is another question, of course. And to me, I think palliative care should be considered as emergency. So, somebody with pain, for example, should be considered as an emergency, and they should have access to the hospital in record time, really. But that's not what's happening.
I agree.
Practice.
I agree.
So we spoke about just now a lot of the gaps that exist within how we look at pain management within the hospital and community setting. We're also looking at palliative care. Obviously, there are gaps. Obviously, there are a lot of needs, but we have resources that we have today. How can we do better in utilizing those resources or optimize those services while we wait for upscaling or improvement in what we have right now? I mean, obviously, with the plan, it's good to have a plan, a strategic plan for palliative care, but we need that to be costed, we need it to be funded, we need it to be supported by all the stakeholders. So that's going to take a while before we get to fulfilling what's in the strategic plan. So what can we do today? Dr. Enin.
I think we have achieved some progress over the years. It's slow. I'm very thankful that certainly I have really very good supporters among the oncology community. So I do feel that in terms of working with oncologists, there is certainly a lot more understanding of pain and palliative care issues in the last 10 years than before. With some of the other specialties, it's a bit more limited. Things with dealing with nephrologists and respiratory cardiologists and others. So those are other areas which we haven't had as much input and throughput with them. In terms of education, I'm involved with teaching and training in palliative care with 5 universities, both undergraduate and postgraduate. So it's slow and steady. So every family medicine person now doing the masters have got to do, say, a month of palliative care.
That's interesting.
So that's slow and steady. But unless there is going to be a significant investment, I'm not sure that we will be able to go any further than that. There are workshops and short courses that people can do to upskill themselves in palliative care. But then again, you need to be interested and want to do this. So things like when we do workshops, there's very few GPs or senior practitioners, consultants that wanting to come in and attend workshops to upskill themselves. Most of the time when we have workshops in palliative care, what we get are nurses. And they are very keen, but they're very limited in what they can do, especially in pain and symptom control.
Dr. Mata, I see you agreeing a lot with what Dr. Nin was saying. Would you like to comment?
Yeah, I do agree with what Eddie is saying with regards to the training. First and foremost, I think the investment from the Ministry of Health point of view, in terms of personnel, in terms of infrastructure as well, that needs to be there. And in the meantime, upscaling the skills of some of the other allied health personnel, for example, nurses, other specialists as well. But again, one of the points about those in upscaling the skills of those individuals, that those individuals, you have to remember their main calling would be in other specialties. For example, if you have a surgeon whose main interest really is to do operations, and if that individual, of course, he would be able to also manage pain to some extent, but it won't be as as good as a palliative care physician, for example, in terms of the enthusiasm, in terms of really going through the process of finding out what exactly they are. Because again, it's not his fault, because he's trained as a surgeon, and that's his primary call would be to operate, for whatever incidences, Yeah. So at the end of the day, upscaling is good. Upscaling the skills of the other allied personnel is good. But I think the investment in making sure that the infrastructure is there and make sure that the personnel are there is very, very important as well.
Well, we talk a lot about resources, but we don't talk enough about how do we share these resources. I mean, obviously, we can't expect the Ministry of Health to do everything. We have to also have the private sector to step up. So, what do you think that the private hospitals, private sector, especially private hospitals, can do better when it comes to improving on this issue of pain management and palliative care? Dr. Martin?
It's not so much the hospital as an entity that actually helps the patient. It's actually the individual doctors who actually manage those patients. Patients going to a private hospital do come at a cost, and cost can be a major stumbling block to access of care. So if there is this public-private partnership that one can talk about, and that is talked about at the level of the management, if the management can come up with some sort of platform where patients from public can be referred to a private center, because as far as costing is concerned, the doctor cost is actually a very small component of the actual total cost to the patients. And, doctors, oncologists, for example, are very willing to actually cut down a lot on those charges just to bring down the cost. But again, I want to stress that a lot of the costs of going to a private hospital, actually it's hospital cost. Yeah. So for public-private partnership to work, it has to be worked out at the management level.
Because when we talk about cancer, it really is a resource-intensive treatment. We need to really look at mechanisms where we can ensure that the quality of care and treatment that we want for cancer patients are able to be achieved as per our aspirations. But we're coming towards the end of the webinar, but I wanted to bring up a very tricky topic, which is insurance. Dr. Nin, is there any insurance that covers, first of all, pain management, the management of pain, and second, palliative care?
I think the short answer is no.
So it's all out of pocket?
Much of it is out of pocket under palliative care. If they come under other specialties and they can put some of the pain treatment under the insurance, that can be covered. Yes, that is a moot point. I want to pick up on what Martin has said about hospital costs and private hospital costs. I would agree with him completely that a lot of the cost is in the hospital charges and drug charges. Many of my patients, when they access the cost of painkillers from private hospital, typically could average out for several thousand ringgit a week.
That's just for pain medication.
That's for pain medication. That's not cancer treatment and other things. So that's usually, I would probably put it as maybe about 2,000 a week as an overall average, although it could be a lot more. So for many patients who may be out of pocket by the time that they have very advanced disease, even the ability to source for pain management is incredibly difficult.
Dr. Martin?
Azrul, can I just add on to that? With regards to the pain management, one of the issues is the continuity of care. For example, patients having access pain medication in a private hospital. The private hospital have got certain drugs that they keep in stock, and when they do go home, with the pain medication that we prescribe in the private hospital, those may be covered by the insurance. But when they go home, when those medicines runs out, and when admin comes in, the kind of drug that admin uses are different. You know, they are pain medicine, but they're probably the generic ones, they're the cheaper ones. And one of the problems that potentially can then arises later on, once admin has managed them and the pain is controlled, a period of time elapses when the pain gets worse because there's some physical reason for that. They come back into the hospital, and then pain management might change a little bit again because of the availability of the drugs that's available to admin, and as the one available to the public hospital may be slightly different. So it's important that when we discharge the patient, when the patient goes home, that we give them a letter to say that, okay, these are the drugs that they're on, and then admin can then rationalize them and move them on to a cheaper alternative. That might help with the cost to some extent.
So it's still very much dependent on how these are managed at the hospital level in terms of these costs.
Yes.
Okay. So we're coming to the end of today's webinar, and I wanted to give a chance for Dr. Ednin to briefly talk about the Hospice Malaysia work that's being done, especially when it comes to the role that palliative care has and in Malaysian healthcare system. Perhaps we could have a few words from you, Dr. Ednin.
I think that I think that this whole couple of months has been very, very interesting to reflect on in terms of how patients, healthcare providers, and the community as a whole is dealing with this COVID pandemic. We've had thousands of patients diagnosed with COVID. We've had just over 100 people dying. And it's interesting to reflect on the perspectives, aspects of, we know the data of COVID patients, but we don't know the data of how much suffering, mortality has it affected cancer patients and others during this period. Maybe in retrospect, do we see a significant increase in death and suffering for cancer patients during this period? We don't have the data on that yet. So whilst all the emphasis has been on the potential effect of COVID, I'm not sure that we've put enough safeguards for patients with cancer and other illnesses and how they could cope with all of this, both in terms of pain, cancer treatment, psychosocial care, and even the nature of how we look after end-of-life care. Families not being able to say goodbye to patients, the nature of how funeral rites have been affected. The memories of people dying live in the children and family members. And when somebody dies in a horrible way, where certain things cannot be done, it affects the well-being and the grief and bereavement of others. So I do hope that after all this is done, maybe it would be nice if Malaysian society could reflect on how we have dealt with this whole COVID thing and where palliative care fits into all this.
Dr. Ednin, I think no true words are spoken, I think, especially during this COVID crisis, where we have seen palliative care come to the forefront on the need for there to be these essential services to be able to help patients who are coming to a certain state where their life is ending, yet their loved ones are nowhere to be found. We're fortunate, I think, that the Malaysian number of fatalities in Malaysia have been relatively low compared to a lot of other countries, a lot of other localities where the fatalities have been high, where there have been services that are needing to be rolled out to help patients who are essentially dying. And in Malaysia, we've been fortunate that our response has been effective of keeping that number very low. So in a way, I can't help but think it's a little bit of a victim of our own success to some extent, that once again, the importance of this service is very much there, but because we don't see the same kind of tragedy in other countries,
I've had a couple of episodes where I facilitated a conversation between a patient and a caregiver and a relative living hundreds of kilometers away and trying to say goodbye through a video conference. And that has been quite challenging, that they are unable to hug and touch each other in the last few days or weeks of life. And that's been very, very difficult for individuals, because, and that's why to me is that when we talk about physical distancing, we are affecting the social aspects of care, and people need to be socially connected. And that social deprivation affects a lot of people badly.
Dr. Martin, last words from yourself.
With regards to the MCO, with regards to the palliative care, with regards to pain management, we've talked about it quite a great deal earlier on. Certainly if you're talking about from the private hospital point of view, that didn't seem to be much of a problem. But it's just to echo Ednin's issue about not being able to be there at the point of death. I think for a lot of oncologists personally, we do see that as a very significant point, and closure at death is important. So I make it a point, for example, those who actually come to the hospital in Subang, for example, towards the end of life, I do make sure that make sure that they do have families with them. Although the hospital have got a no visitor policy, but in patients with cancer who are dying, I do ask the manager to make exception to that rule. Again, closure at the point of death is actually extremely important.
So I think that the COVID-19 crisis has been exceptionally thorough in actually pointing out some of our gaps and weaknesses, but also I think our strengths. And nowhere at our time of history has our healthcare system been put to a stress test to such an extent where we will actually see where are the strengths, the weaknesses, but also the gaps and the needs that we have yet to address, despite the many, many plans that we put into place. And I would like to just take this opportunity to thank all our sisters and brothers, the women and men who are working for us, people like yourselves, Dr. Ednin, Dr. Martin, who are working hard to improve on the quality of life of Malaysians, to help Malaysians who are needing assistance in this really tough time of COVID-19. Especially, I make a special shout out to the women and men of the Ministry of Health who have been at this thing from January until today. We are only going through the MCO and the CMCO, and then we're already crying that it's too long and all this. But these courageous individuals have been working since January in ensuring that COVID-19 is able to be contained and managed. And now that we have been able to flatten the curve, so to speak, perhaps we should be able to honor the sacrifices of everyone involved, whether it's the cleaners at the hospital or the police officers or the different individuals who are cleaning our streets, that we do our part to ensure that we're able to keep the numbers low, but also to support the efforts of everybody involved. So with that, I would like to once again ask that we say a prayer for all these people, both in the spirit of Hari Wesak today and also Ramadan. But I would like to again thank you both, Dr. Ednin and Dr. Martin, for spending your time with us to talk about a critical issue of managing pain and palliative care in cancer during MCO. With that, we end our webinar. Today, I would like to encourage those who have not liked the Cancer Care Working Group Facebook page to do so, and to also support the hundreds of individuals who are working in the delivery of cancer care in Malaysia, which has been a challenging time for all of them to actually do these services. So with that, thank you all. Assalamualaikum warahmatullahi wabarakatuh, and a very good day. Take care.
Thank you.
Stay safe.
Thank you, Azrul. Stay safe, everyone.
Bye.
Thank you, doctors.